Hi, Dr. Marston. How are you today?
I'm good. How are you today?
I'm well, thanks. So, Dr. Marston and I um, hope to provide some guidance and some ways to help you challenge the findings that we get in the psychological exam reports that SSA sends our clients to when they're evaluating their disability claims. And our goal today is to provide some insight and perhaps some ideas of what's missing in those reports as well as what's in those reports. Dr. Marston, in his practice, has also performed these evaluations, these examinations, and so he's got some really good insight to share with us, as well as insight from his private practice. I'm going to turn it over to Dr. Marston for a moment to give us some of his thoughts as well.
Thank you. As Teresa said, I'm Dr. Marston, Dr. Daniel Marston. I have a practice out in Western Pennsylvania, and I have been doing these evaluations for a number of years. I previously did them directly for Social Security disability, and I have been doing them privately for a number of years for different attorneys and organizations. And I have seen over the years a number of places where the evaluations that are submitted for disability are often lacking. This could be
Mhm.
because they either were too short or information wasn't addressed or for a number of reasons. So uh, I thought that this presentation would be a good idea because then we could move on to help those of you watching this understand what are some good ideas for trying to challenge some of the findings or build on some of the findings that might be in the psychological evaluation submitted for a disability.
Thank you. So what we thought we would do today is sort of a conversation about some of the questions that come up often enough. We'll follow along through the PowerPoint and, of course, add things as we go. So, Dr. Marston, the first issue I'd like you to address is how you and I've talked about the listed impairments, and I know you're familiar with them. How do we correlate those to the evidence from these medical psychological evaluations and then use that information in formulating our questions to the vocational experts?
Sure. I think what is the first thing to um, notice and to keep in mind when you're looking at some of these psychological evaluations is that you need to focus on what's in the evaluations and what is in the treatment records. But you also keep in mind that just because something isn't there doesn't mean that it doesn't exist. Sometimes there's an attempt to try to flush out the from the reports and from the notes some information that relates directly to the limited impairments, and sometimes that information just is not there. It these evaluations that are done either through the disability office, Social Security still sends people for psychological evaluations, or evaluations that are done as part of the treatment records. Some often are very limited. They are very limited because of time or because of purpose. And I'll get to that in a second. But
Mhm.
what what you need to keep in mind is just because something isn't in there doesn't mean you're going to find it, but it also does not mean that that limitation does not exist. And what I brought up before about how sometimes the treatment records don't have material in there because of purpose. What I mean there is it's important to keep in mind the treatment records are primarily written for insurance companies, for health insurance companies. 90 plus percent of the healthcare services are provided through psychologists, psychiatrists, clinical social workers, licensed counselors are paid for by insurance. So the providers are writing the treatment reports and the treatment notes for insurance providers. And the notes have an almost opposite purpose from what is needed for a disability claim. A provider, when they write their notes, they need to show progress. They need to show where the person is getting better. So they don't focus so much on what impairments are still there or how those impairments are affecting the person, because they are needing to move forward with discussing progress. And that is something that can run counter to what you're looking for when you are trying to find out about of limited impairments, when you're trying to find out about some specific impairments that the person might have. So there are a couple things in reference to your question. One is you need to go through the psychological evaluation and the treatment notes to find any reference to the limited impairments. That's certainly the first step. But if you don't find it, you can't assume that because a limitation isn't discussed in the notes or in the report, it doesn't mean that it's not there. And sometimes you just have to say, well, this question about whether the person has this impairment, it isn't answered in the evaluation. And that may lead you to seek out your own psychological evaluations from a psychologist that you work with, who you know you can say, hey, I need you to address this specific limitation because we just don't have any information about it.
Okay. One of the things that sometimes we see, I may be jumping ahead a little bit, a lot of times we will see in those records that the patient is stable. What does that mean in your world?
Well, stable can mean it's interesting that stable doesn't necessarily mean good or bad or unimpaired or impaired. All stable means is they were functioning at this level before and now they're functioning at this level again. And I think, you know, the word stable you would hear a lot in treatment records.
Okay.
And I think I need, in order to understand the word stable as it appears in treatment records, I think it's useful to go back to what I was saying before, that these notes are written for insurance company, and stable
Mhm.
just means the person didn't get any worse. Now,
I see.
for the case of disability, that's not a particularly relevant statement. But when you're trying to make the case to the insurance company that the treatment you are providing is worthwhile, the person not getting worse is a relevant point, because insurance companies will consider treatment to be something they're willing to pay for. One, if you can show progress, but if you can't show progress, if you can at least show that you're providing treatment, help keep the person from getting worse. And so not getting worse doesn't really say whether the person's impaired or not. It just means what it, just that the person didn't get worse. They're the same as they were before. So I would say that stable is really a treatment word, is a word relevant for
Okay.
treatment. It is not a word particularly relevant for deciding if the person is impaired or not.
So it's not relevant at all to functioning.
Exactly. Exactly.
Okay. Any other thoughts that you wanted to share in terms of our questioning of our vocational expert?
Sure. And one question that I knew we specifically wanted to address was about whether there were any important points that you need to keep in mind when you're questioning a vocational expert during a disability hearing. And I think what is important when you're questioning a vocational expert is that you try to get them to be specific about what they are talking about when they make reference to a successful working situation. And one thing in the PowerPoint slides is we have the word successful purposely in quotes, because successful can mean a lot of things to a lot of different people. And when you have the vocational expert up there, you want to really try to clarify with them what definition of successful did they use when they were writing the report or when they were making a decision or when they were testifying, whatever is the case. So if they say they think the person can be successful in a certain type of work situation, how were you defining successful? And what did you base the decision on? And one thing, there are two strong points I want to make about that. One is that you want to gather, if you get specific about what they mean by successful, then you can start to ask them, well, where did you get that information from? Where did you pull it from? And what's particularly relevant there is if there were multiple evaluations or if there were multiple treatment records, which one did you give weight to? Did you base this equally on all of them, or did you give particular weight to one, and why did you do that? One
Mhm.
example of why that's particularly relevant is sometimes when you talk to a vocational expert, they will lean towards the evaluation report that came from Social Security Disability, and maybe sort of shy away from any evaluation that came from a treatment provider. That's just an example, and you want to ask them specifically about that and ask them why did they give more weight to the Social Security disability person and not the treatment um, provider. The other reason why it's important to clarify this term successful is, like I said, one is because it helps you clarify where they got the information, but the other is how are they defining successful in terms of a full day? In other words, they may talk about, the vocational expert may talk about, well, the person showed they can do this, or they can function adequately in this area. But there's a difference between being able to, say, pay attention or remain focused at one point in time. It's an entirely different thing to say that they can do it for 8 hours straight. And a lot of times, what vocational experts will not take into account is the fact that the person has to maintain that level of functioning for 8 hours straight, and 8 hours that vary. One example of what I mean with that last part is um, you will have vocational experts, not all, but some, who will make the suggestion that someone could, say, work in a factory because they can maintain attention and they can stay focused and complete a task sort of on a rote basis, sort of like repeating the same thing over and over again. But their assumption will be that if they think the person could do that for 8 hours, the assumption will be that that 8 hours will always be the same, that there's no stressors, there's no change, there's no increased demands. But that rarely, if ever, happens in any work situation. Equipment breaks down, um, something slows up or speeds up. There's pressure coming from above, there's pressure coming from other workers. And if you are saying that someone can function as far as doing something like remain on task, you have to ask the question, do you mean they can do that if there's no stressor or there's no change or there's no increased demands? Because no job is ever like that for 8 hours. There's always something interfering.
Mhm.
So, it, just to summarize the points regarding that last question about vocational experts, you need to clarify what they mean by the word successful. How are you defining it? Where did you pull that information from? Did you give weight from one report or did you give more weight to another? And the third is, what do you mean about this person's ability and functional level in the context of a full 8 hour day that has changes throughout it. And those are three things vocational experts often don't bring up. I think one last point I'd want to make is it's important to keep in mind the credentials of vocational experts. I mean, vocational experts do a very important job, but their training tends to be very limited. And it is not typically weighted extensively in understanding mental health or psychological diagnoses. And it's not that there's anything wrong um, with their presentation, but sometimes your best way of addressing what a vocational expert says is not just to question them, but to make sure you have your own information from somebody who's got a different perspective on the situation, so you get the full picture.
And so let's sort of segue from that into the full picture and the evaluations. Um, how do we rebut the evaluations that the consultative examiner might do? A couple different situations. So what I want to talk about maybe first is how do we do that? How do we rebut those reports from the Social Security examiners when we don't have a client, a claimant who's had a longitudinal history of treatment? Can you give us some suggestions how to do that?
Sure, sure, that's a good question. So what you will find when you don't have the longitudinal notes, when you don't have the longitudinal data, that usually will come about when the person has not been in treatment.
Right.
So the first thing I would go back to is this issue of just because the problem isn't mentioned doesn't mean it's not there. There could be a lot of reason why someone hasn't been in treatment. I'll talk about that in a minute. But what you primarily want to focus on is, again, this whole idea that just because the longitudinal data doesn't exist doesn't mean the impairment isn't there. So that's the first thing you want to do is you want to realize that the longitudinal data can be helpful because it can show where the person maybe is continuing to have impairment, but it's not absolutely necessary. So you start with that issue of just because it's not there doesn't mean it doesn't exist. You also want to keep in mind that it's a legitimate question. Why is the person not in treatment? You know, if their problem is bad enough, why would they not have sought out treatment? And it's useful to keep in mind that um, sometimes the lack of treatment can, in and of itself, be reflective of a problem. People who are depressed often don't seek out treatment because they're too depressed to make it, or they're too depressed um, to participate. I've had individuals, and this would seem to be counterintuitive, which is why it's always been surprising to me, who went to see a therapist, and the therapist said, I can't help you because you're too depressed and you're not participating in treatment. So, in that case, which is rather bizarre if you think about it, it's like, well, wait a minute, isn't
Yeah,
that why I'm coming to see you?
sure.
But now, giving those treatment providers the benefit of the doubt, I'm sure they might have meant something like, I need to recommend that you go see another provider. I've said that to people that I see in treatment. Maybe I thought, well, counseling isn't really going to help you until maybe you get on some medication to help give you a little bit more energy, a little bit more motivation initially. But uh, people don't necessarily hear it that way. They may hear the person saying, I can't help you, but someone else can, but they only hear the first part.
Sure.
I can't help you. So it's important to keep in mind that the lack of treatment doesn't mean that the problem isn't severe. lack of treatment could be a reflection of how severe the problem is that has kept the person from participating in treatment, from continuing with treatment. So as far as this lack of longitudinal evidence, again, the first issue is keep in mind that just because it's not there doesn't mean it doesn't exist. The other is maybe delve into, if you don't have longitudinal data, why don't you? And if it's because the person isn't in treatment, why are they not in treatment? Because, like I said, sometimes the lack of treatment um, may reflect the severity of the problem. And also, when you are looking at the lack of longitudinal data, you want to keep in mind then that you are only relying on whatever reports you get that are done in the moment. And so lacking longitudinal data, you can't replace that. If you don't have it, you don't have it. But you need to make clear then with your case what's missing. And what's missing is that if you have only psychological evaluations, again, I go back to, you need to keep in mind that all you have are these snapshots in the moment. And you need to take into account what that means. One is, like I said, you're not getting a reflection of how the person does over time or in different situations. You also want to watch for, was the evaluator paying attention not only to what the person said, but how they appear during the evaluation.
What do you mean by that? Maybe give us an example.
Sure. And before I give the example, let me clarify that this was brought up in the context of longitudinal data. And longitudinal data often means the person is in treatment. And as much as there's a difference in treatment as far as being able to show how the person's doing over time, there's also also a difference in how the notes are written. There's also a difference that if you're in treatment, there's more of a connection. So in fact, it's called a therapeutic relationship. So if I'm seeing someone for therapy, there's more likelihood that I'm going to talk about not only what they say to me, but also how they appear. If they're telling me they have trouble staying focused, I'm going to want to look during the session, are they having trouble focusing while I'm talking? But with a one-time evaluation, that often doesn't happen because there's not that connection. So the person only is reporting what the person reports and not what they're observing. And also a therapist or a psychiatrist will want to get more of a sense of how the person has been over the past several weeks. So they'll ask about not just how are you doing right now, but how did you do yesterday, the day before? How have you been doing the past week? So there's more of an opportunity to talk about what has been going on over time with the person as opposed to just in the moment. So it strikes me as I finish up the responses to that question that what you're really doing if you don't have longitudinal data is being very focused on what you don't have, and going back again to this theme of just because you don't have it doesn't mean it doesn't exist. And you don't have how the person does over time. You may not have a clear view, not just of what the person reports, but how the person looks to the evaluator. And you may not have a clear indication of why the person didn't stay in treatment if they're not in treatment, or why they didn't seek out treatment. And oftentimes not being in treatment can be a reflection of just how severe the problem is.
Okay.
And if I could, do you mind if I build just a little bit more on that?
Go right ahead. Go right ahead.
Because one other thing that I noticed, and I noticed as I know it's on the slide there, that what when you question an evaluator, so if you don't have longitudinal data, what you will probably have is an evaluator who's got sort of like a one shot
Right.
snapshot of the person. So you want to make sure that the evaluator, if you don't have material from a therapist, or even if you do, someone who's been treating the person, you want to make sure that the evaluator not only talked about how the person looks during the session, but they ask questions about what does a typical day look like and how do you define a typical day. Because one other thing that you don't get with the absence of longitudinal data that you might get if you have it is the a sort of reflection that when a person is on disability, when a person is seeking disability, their typical day often involves very little. So if they say, well, I'm able to function every day, that literally may be all they were able to do is get out of bed and go make food for themselves
Mhm.
and their family and maybe take care of some laundry or some cleaning things around the house, but not anywhere near the level of stress that you would have when you're trying to work through a full 8-hour day. So you want to make sure that when the evaluator said something like the person is able to function every day, you want to make sure that there's a clarification of what does an average day look like for this person, because it may actually involve very little. And what does function mean? Again, because it may be that their functioning every day is actually involving very little activity or very little stress.
So most often we will have the report and not necessarily be questioning that
Yeah,
evaluator. So it would be important for us to look in their report for those exact things or lack of those things.
exactly, exactly. And there really is, I realize, sort of a weight in this whole process of being willing to admit clearly to yourself and to your client what you don't have,
Mhm.
because rather than trying to find it, because it just may not be there, and you're really doing yourself a disservice to yourself and your client if you're not just admitting, well, we don't have this, and we can't not only make it seem like we do, but we can't let other people, whether it's a vocational expert or an evaluator, make it seem like, well, we addressed this issue and the person doesn't have an impairment. I go back to just because it isn't in the report or in the notes doesn't mean it's not there.
Okay. So let's switch gears a little bit again.
Okay.
We've talked about the various um, listings in terms of the mental health and the various mental health conditions that exist. And it seems to me that a lot of those conditions have crossover. You can't pigeonhole just anxiety or just depression or just whatever it may be. So let's talk about that a little bit.
Sure. There's often a lot of crossover between what depression looks like and what anxiety looks like. They do share a lot of the same symptoms. And even to the point that what I've noticed on some of the functional impairment lists that people fill out for these evaluations, there will be a degree to which uh, they may mark things under depression, but then not make reference to it when they're discussing anxiety because they already referenced it under depression. And that's not accurate. For each condition that you're considering, you want to make sure that you're starting with a clean slate. One example could be that um, repetitive negative thinking is a major part of depression and is a major part of anxiety. Feelings of hopelessness can be a reflection of depression and can also be a reflection of anxiety. So, in whatever way the person is trying to determine in an evaluation or in treatment notes that the person has a condition, you want to, like depression or like anxiety, you want to make sure that they're giving a clean slate each time and starting with all the symptoms and not saying, well, if this is a symptom that relates to depression, it can't be a symptom that relates to anxiety. That's not accurate. There's a lot of crossover between depression and anxiety. It's also useful to keep in mind that there is a difference between a condition and a diagnosis. Depression is a psychological condition. It involves sadness, it involves feelings of hopelessness, helplessness, lack of motivation, lack of energy, crying, repetitive negative thoughts. Those are all factors related to this general construct of this general condition of depression. But there are a number of diagnoses that reflect depression: major depressive disorder, persistent depressive disorder, um, adjustment disorder with depressed mood. There are a number of different diagnoses that reflect that carry with it depression. So saying someone doesn't have major depressive disorder does not mean that they don't have depression. There are other diagnoses uh, that go along with depression other than major depressive disorder. And um, so when you've got these functional impairment lists, they seem to reflect more the diagnoses than the conditions. And again, I say all that because it's important to keep in mind that just because a person doesn't meet the criteria for one doesn't mean they won't meet the criteria for another, whether it's a condition um, or whether it's a diagnosis. One other thing about the fact that depression and anxiety mirror each other is it's important to keep in mind that your client is not the expert in the diagnosis. I see that a lot. I see a lot of times in therapy or in evaluations where someone will come in and I'll ask them what they identify as their problem, and they'll say, "Well, I'm really depressed." And then I'll talk to them and find out that their symptoms are more characteristic of anxiety than depression. So if you get an evaluation for someone who comes in and says, "I have problems with depression," and the evaluator says, "Well, they don't have depression," that's only asking half of the question. Saying what they don't have doesn't answer the question, do they have something else?
Okay.
Because depression can look a lot like anxiety. And that can be really relevant for the functional impairment list because you want to make sure they're starting with each diagnosis or with each impairment with a clean
Mhm.
slate. But it also relates to the fact that people don't necessarily know what their problem is. They know what their symptoms are, they know what's making them feel bad, but they don't know if that's depression or anxiety. Um, and again, one last thing is this other thing about there being a lot of crossover is important to keep in mind that that's important for something like bipolar disorder because bipolar disorder has sure right now, and I have that it's saying it's still recording. What do
And
you have on your?
it's telling me record also.
Okay. All right. Now I'm going to
Okay.
pause it. So the other thing that I wanted to make reference to here is that this whole idea of there being crossover is particularly important for a diagnosis of like bipolar disorder because bipolar disorder has a lot of potential crossover. Um, it's got depression in it. The bipolar disorder is manic depression was another name for it at one point. Um, mania, which is the opposite end of bipolar, because bipolar means switching from depression to mania. Mania often looks like anxiety. And there is a bipolar 1 disorder, which is where there's a clear change from depressed to depression to mania. But bipolar 2 often looks shorter the durations are shorter. So it often can look like there's a mixture of depression and mania kind of at the same time because they can change so quickly. There's actually also another diagnosis called cyclothymic, which is much more rapid. So bipolar disorder, which also, by the way, has irritability as a possible symptom, there's a lot of this crossover in that diagnosis. So it can really be important to try to clarify what you have, um, and to clarify each of the symptoms that the person is talking about and coming up with um, an understanding of which symptoms the person is actually experiencing. Because there can be a lot of crossover, and it can be difficult unless you're doing a very detailed evaluation to be sure that you're accounting for everybody's symptoms. And I guess as far as a specific recommendation, that's what I'd want to make. You want to make sure the person's symptoms are being accounted for. If they don't have major depression disorder, then why are they having poor motivation? Why are they having poor energy level? Why are they seeming like they're depressed? This is particularly an issue when it comes to post traumatic stress disorder, because it's important to keep in mind that post traumatic stress disorder is a very specific diagnosis related to trauma. It is not the only diagnosis related to trauma. In fact, every sort of condition, depression, anxiety, anger management, can be related to trauma, even if it doesn't specifically relate to PTSD. PTSD is a diagnosis that specifically relates to reliving trauma. But that's only one way trauma can affect someone. They've been the victim of trauma and they just relive it over and over again. But often the biggest impact trauma can have is it causes the person to just have a negative view of the world, a negative response to the world, a negative um, functioning level in how they interact with the world. And that's not PTSD, but it's still a major impairment. It's still a major difficulty. In fact, there are two specific diagnoses related to trauma: other specified trauma related condition and unspecified trauma related condition. And those are both specifically related to trauma, but they are different than PTSD. They're more accurate for reflecting when the person has depression that's due to their trauma, or anxiety due to their trauma, or anger management due to their trauma. And it isn't better or worse than PTSD, it's just different. But the bottom line with all that is trauma can impact people in many different ways other than just PTSD. And that's a good way of thinking about this whole crossover of different diagnoses and being clear that each symptom is being accounted for
Okay.
in the
And,
evaluation.
okay. So one of the things that we see a lot in these evaluations that Social Security sends our clients to is what I've called and I think this is the correct terminology, the mini mental examination.
Mhm.
Can you tell us a little bit about that, or some of the other cognitive intellectual functioning evaluation parts of those exams, and how we can use those to help our clients?
Absolutely. Um, just to clarify, and it's called the mini mental status examination. The only reason I clarified that is because sometimes you will hear it referenced as just MMSE. So it's important. It was important to clarify that
Sure.
S is in there because that may be how it's described. The mini mental status examination is only considered a screening tool, as are some of the others. There's the Montreal uh, cognitive test or cognitive assessment test. Um, there is the brief cognitive screening assessment, but the mini mental status examination is probably the most common. And it's important to keep in mind that it is by screening, all it means is it was only ever developed to sort of identify whether a problem might be there. but it's not considered to be the full picture of the person's cognitive functioning. And there's two things to keep in mind about why that might occur. With the mini mental status examination, you only have a few points attributed to each section. So, for instance, attention and concentration only makes up like 4 points on the 30 items of the instrument. So you could have severely impaired attention and not get any of those questions right, but still pass. Pass, meaning you're not identified as having a global impairment, because 26 out of 30 is considered to be sort of the cutoff for someone who shows no global impairment, meaning their functioning overall is okay. But just because you have a pretty good score overall doesn't mean that specific areas aren't impaired. Where I see this most is probably in memory. There's a section on the mini mental status examination where you're given a list of words and asked to remember that list 5 minutes later. People will get every other part of the test right, but miss that. Well, that's pretty significant. If you can't remember a couple words after 5 minutes, your memory is clearly severely impaired, even if everything else is okay. So you have to keep in mind that the screening test is only a screening, and it's only meant to give a very brief snapshot of the person. And you want to make sure it's being looked over to see, well, did they have any severe difficulties in any one or two areas? The other thing is that the mini mental status examination is not particularly good at even identifying major impairment with somebody who had a higher level of functioning to begin with. So if you're if you have a PhD or you have a master's degree, or if you're a lawyer or a doctor, your level of functioning is probably pretty high to begin with. So you may get a 30 out of 30 on the mini mental, but it still reflects a pretty severe impairment from where you were functioning before. Because remember, things like dementia, that's how they're defined. Is an impairment, is it a decrease in functioning from where the person was before? And that again is an issue that still needs to be accounted for.
So if you don't have that knowledge or information of before, having that screening test sounds to me is even more limited.
Right, exactly. And it just shows just how limited that is. And the only thing you really can do is, again, if you feel that there's an impairment there that's not coming up on the mini mental, is you have to get a more detailed assessment. A mini mental status examination is not a neuropsychological evaluation. The neuropsychological evaluation is multi-hour, multitask, very detailed evaluation. So if you have a person who seems to have a cognitive impairment, but just does well on the mini mental, that's not the full story. A more detailed cognitive assessment or a more detailed neuropsychological assessment or an IQ test. The other thing to keep in mind is the mini mental doesn't really tell you anything about IQ. And it may be the person's IQ is more the issue than the person's cognitive function, because those are two different things. By the way, one other thing to keep in mind about doing an evaluation is a diagnosis of intellectual disability no longer requires an IQ test. It can be done just on functioning and adaptive ability, and even if you don't have a full IQ score. So the bottom line is those brief screening instruments were never meant to be the full picture. And it's important to keep that in mind if you have that and that's all you have.
One of the things, and you referred to the forms earlier that have the checkoff boxes. One of the forms that is used by Social Security includes terms of none or mild or moderate or marked or extreme. Are those terms generally accepted in your profession? And if so, then how do we challenge those when they show up in the report?
Sure.
What can we do?
Sure, that's a good question. And no, I would say they are not well defined, at least as they're used in the functional impairment. And that's where it can get a little bit confusing. So for instance, for something like major depressive disorder, there is mild and moderate and severe, but that's really only based on the number of symptoms that the person has, not their functional impairment. So major depressive disorder, moderate level, is still a very significant condition, even if it's not listed as severe. So the mild, moderate, and severe, as it's used in, say, the diagnostic manuals like the DSM-5, don't reflect the same thing as is reflected on those functional impairment lists. Those functional impairment lists, when they use none, mild, moderate, marked, and extreme, are very subjective based on the person's opinion. So you want to make sure that whatever one of those is used, how they defined it. What did the evaluator or what did the treatment person use to define that term? Because they are not formally defined in an objective way in any materials used by mental health professionals. Um, and so the answer to that question is no, they are not used that way, sub, objectively and in a well defined way in my profession. So you want to make sure that the person giving those rankings, giving those ratings, are being clear on how they defined them, because they're very subjective and they don't reflect anything that's actually well defined in the materials we use. And it can get a little bit confusing, like I said, because the same words are used. Mild, moderate, and severe are used in some of the diagnoses, but they mean something different than functional impairment.
So it sounds like if we're using them as they are defined in the DSM 5, that's what could help us to challenge them.
Right. That could help because, and here's an example of that. It is weird, and I can't think of any other word to describe it, that there is a major depressive disorder diagnosis that is called mild severity. So it's technically mild major depressive disorder. The mild version of major depressive disorder is still a very significant impairment. Um, it just means the person doesn't meet as many criteria as they do for the severe version, but it's still it doesn't have anything to do with the person's functional level. It's not like, well, they just had the mild version, so they're okay. No, it's still major depression. It just doesn't have all of the symptoms that the severe does, but the symptoms that are there may still be very functionally difficult, and making
Okay.
clear example with the one is severe major depressive disorder has active suicidal thoughts and plans. Mild does not, but just because a person's not suicidal doesn't mean they're functioning okay.
Okay. So we've got just a few more minutes left in our time slot. Um, Thought I'd ask you if you've got any recommendations. We often will send our clients to someone like yourself
Right.
For an evaluation. Um, and so, what kind of tips or information or recommendations do you have as we send our clients to see you or someone like you
Sure.
that would be helpful?
Sure. There's a couple things, and I say this making very clear that that I know when you send someone for an evaluation, you're not coaching them on what to say. You just want them to be honest, as we all do. But you also want to make sure that they're giving the information that the person evaluator needs to hear from them. And as we've seen throughout this, sometimes the evaluator doesn't ask the question or doesn't get the information. And so it's good if you can help your clients at least be a little prepared for what they would need to make sure the evaluator knows. And a couple specific recommendations that I have is make sure that they're focusing on the problems that they're having and the symptoms that they're having and not their diagnoses. And that's important, one, because they just don't know their diagnosis. I mean, they may think they know it, but it's up to the evaluator to determine what the diagnosis is. They just need to tell them where are you having the problems and what are your symptoms? It's also important in that area because clients will sometimes think, well, I have bipolar disorder, so I'm going to qualify for disability. That's not true. People with every diagnosis work. People with bipolar disorder work. People with schizophrenia work. Having a diagnosis doesn't in and of itself um, mean you can't work. So they got to focus on what their problems are, what their symptoms are. And they're also needing to focus on how things are happening to them now, not, well, I've had this problem for 5 years. Well, it doesn't matter what happened 5 years ago. We're working on how things are now. Also, you want to make sure that they're not saying things like, uh, I have a lot of problems with my mood if I'm not on my medication. Well, that doesn't really mean anything because the only response from disability would be, well, stay on your medication and you can work. So they need to talk about how they're doing even with whatever treatment they have. Um, Also, try to make sure they're ready to talk about why they're not in therapy, if that's the case. What was it that led to them not being the case? You also want to make sure they know that qualifying for disability is often a high bar. So now is not the time to be self-conscious um, about how much their problems are interfering. And this may be where the attorney has a particularly useful role because, it's hard to admit how much your mental health impairment is function. I've seen people much more often downplay their impairment than oversell it, so to speak. And it's important for people to know now's not the time to be self-conscious about it. You got to let everybody know exactly what's happening so they can make the best determination for you.
Okay. Any other thoughts or tips that you could provide to us as we finish up here this morning?
Sure. And I think we're about out of time. I think we're coming up on it, so I won't take too much time here. But I would say that a lot of the recommendations we're talking about come down to a few things. One is um, uh, uh, don't assume that because something isn't in the report or isn't in the notes, don't assume that because it's not there doesn't mean the person doesn't have the problem. You want to be clear that you know what the problems are that your client is reporting because you want to make sure those are accounted for. If the person isn't depressed, then why are they having these problems? What are So you want to make sure that's it. You want to really consider whether you need to get your own evaluation done, not because you want to get someone to say what you want them to say, but someone that you're confident will address the symptoms that other people seem to be ignoring or seem to be passing over or seem to not be giving sufficient analysis to. You want to help your clients be comfortable with being open and honest with whoever's asking about their disability so that they are getting the most honest decision they possibly can. And again, that word is honest, I think, comes up as being the most important thing to get across clients is make sure their best bet is to be as honest as possible. But honest means not only admitting to your symptoms, but admitting to where they're interfering with your functioning and where you tend to have difficulties, when they tend to occur, and making sure that each of those problems are addressed in whatever evaluation, that the question is answered, why does the person have this problem? So that you can make the best case you possibly can.
Okay.
All right.
Thank you. Your insight is invaluable. I would just note that you and I talked about this previously in terms of whether the individuals watching this program have other questions. If they can contact you, your information is on the slides. I just wanted to confirm that was okay.
That is absolutely, that would be fine. If anybody has any questions, just feel free to let me know.
Okay. Thank you.
All right. Thank you.
Uh-huh.
This was great.
Okay, so
All right.
it stopped.
Okay.
So if we could do this, and I know you have
Hmm?
someone coming up soon too, but I'm going to look and see if I'm wondering, first of all, you did pause yours, but I wonder if you have a more complete recording than I do. Do you know what I mean?
Uh,
And I don't know. I'm gonna, obviously, when I sign off, it'll download it.
okay. Well, I tell you what I'm gonna do. Now hold on a second. Let me see what just. Oh, I have two computers running. I'm wondering why I didn't. Okay, I'm going to.
You're
I'm gonna
still
stop.
recording.
Yeah. Oh, I'm.
It
Oh,
says you're recording.